Afternoon, everybody, and welcome to this week's deep dive, where we have a very, very important topic that we're going to discuss: fertility in hematology and oncology, and in particular, fertility preservation in patients with hematological malignancies. So, I really want to welcome Dr. Lizette du Plessis, who's our speaker, and who will be introduced shortly by Professor Fatima Bassa, with whom I have the privilege to co-chair this afternoon's session. I just want to go through a few housekeeping things, and first thing to remind everyone of that all these sessions are recorded and available on the Blood SA website, but I would like to strongly recommend that we get together here, because I think the interactive the time we have to discuss things together is so valuable, and it's often, in my experience, difficult to find the time afterwards. But nevertheless, sometimes we can't attend, and then the recordings are there, or if you want to encourage someone to go and watch, if you've enjoyed a particular session, please do so. Go and have a look at the Blood SA website. It's fantastic. There's so many great things there. So during the course of this session, if you have any comments or questions, please put them in the chat box. This meeting belongs to all of us. So take part, bring something, give something, ask something, whatever you like. CPD points for HPCSA registered people would be sorted out automatically. Blood SA will submit your presence if you've been in the room for at least 60 minutes. In total, that will be submitted automatically to the HPCSA. If you're not from South Africa, welcome as well. Then you can email Melanie Davids at the address on the screen, and you can be sent a certificate of attendance. Thank you. Next slide. Thanks, Gardine. This is the team that makes things happen behind the screens: Professor Estelle Verburg, Dr. Gardine Kritzinger, Ms. Melanie Davids. Thank you very much to all of you for the wonderful work you do. And with that, I would now like to hand over to Dr. Bassa to introduce our speaker of the day and the topic. And then we will make time for some good conversation and questions and discussion at the end. Thank you. Over to you, Fatima.
Hi, good afternoon. As Murphy's Law will have it, we've just finished load shedding, so we're in the process of switching back on. The generator has just stopped and we've got power back, so apologies for that break. Welcome to our presentation. We embarked on this topic. Okay. But I'm just going to go next door. It's
We'll just give Fatima a moment. Sounds like there was some feedback coming through, potentially through another phone or something. She's just moving from one office to another.
Unmute. Hi, can you hear me now?
Yes, we can hear you well.
Okay, apologies, we just switched back to ESCOM now. So yeah, we're back on track, and hopefully we shouldn't have any issues. So welcome to our presentation. We embarked on this topic because of the challenges that we were having with fertility preservation in our patients. And we found it quite interesting looking at the recent literature on this topic. And I thought it would be good to see what the experiences are in the rest of the country. Because as Lizette will point out, it's not as easy as they make it out to be. There are several challenges. And we decided to stick with the topic of hematological malignancies. I mean, there's another whole area of stem cell transplantation with the benign hematology, but I think because of time constraints, we won't discuss this. I would appreciate feedback from other centers. And just to say, there's a lot of gray areas and lack of data, especially with the newer agents. So there are some uncertainties, but we'll try and present whatever we have available in terms of robust data. So I'll hand over to Lizette.
Right, Lizette, you're welcome to share your screen.
Just quickly go there.
There we go. Can you see the screen?
Beautiful. Looks
Thank
good.
you. Right. Yeah, so I think this going over from the one type of electricity to the different subset of electricity is more stressful than this presentation. So yes, as I was introduced, my name is Lizette du Plessis. I'm one of the senior regis here at Tygerberg. And I think before I even start, this for me has definitely been an interesting conversation starter with my patients. Ever since I started reading more about it, I've noticed in my own encounters with my patients that I definitely think that my own, the way in which I relate to my patients and what I tell them and how I can try and give them an idea of what their future will look like has improved since reading up about this. So if you are very experienced and you don't have any questions relating to this topic, I might not be able to offer much more, but if like me, you're newish to the field of hematology, then I urge you to, at the end, I'll share it as well. There's a lovely article, and even if you just read this one article, it will, I think, add on to your own knowledge and empathy with these patients into what they are going to endure, possibly in the future. And I think it's an important topic that we mustn't forget about, seeing as we want our patients to live healthy and full lives and not only just cure them from whatever ailment they have. So just the first couple of slides is more as an introduction with regards to the amount of patients that we have, that we are looking at worldwide or maybe countrywide, and to see what the need is for this. So in a 2015 ASH study, they at the bottom, they noted that there was more than a million survivors of acute leukemia, Hodgkin's lymphoma, non-Hodgkin's lymphoma, and with about 130,000 added to that number every year. What I also noted was a significant improvement, obviously, yearly of having more transplant survivors. So this number would likely be a lot more by now, 8 years later. If you look at those ages that are presented there, a significant amount of your patients with Hodgkin's lymphoma and ALL are less than 50 years of age at the time of diagnosis, and a moderate to large amount of patients with non-Hodgkin's lymphoma and AML are also less than 50 years. Interesting, in the subsection of patients less than 40 years of age, 45% of your allos and 25% of your autos are less than 40 years of age. Together with that, in a study where they looked specifically at the teenage and young adult population, which would be between the ages of 14 to 24, more than a quarter of all the newly diagnosed malignancies are hematological malignancies, and of which about 19% are your lymphomas and 9% your acute leukemias. So you can see that that's quite a large amount of, yes, it's the US. We don't have our own data for that necessarily, but it's a young growing population. And yes, we might have all of these diseases in an older cohort where perhaps they've completed their families and they don't really have such thoughts anymore. we know that there's a large amount of patients who have not yet, who don't have a family yet, who've not maybe even thought about having a family yet. And it's this population that we're looking at today. So the scope of the problem is actually more than just the, as you see in the number 1, the gonadal dysfunction, the infertility. It's actually encompassing that together with sexual dysfunction. So we know that your chemo and radiotherapy can significantly influence and alter our patient's ability to actually conceive. It has significant effects on everything from your hypothalamic, pituitary, endocrine axis, your germ cells, your and then even potential uterine dysfunction. And we're going to look at that into depth. But this slide is more just to note that sexual dissatisfaction is actually a significant repercussion of our patients, like what they go through with all of the physical and emotional trauma. They did a study where they looked at transplant survivors, and 80% of females and 46% of male survivors described sexual dissatisfaction, whether in changes in libido, dyspareunia, ejaculatory abnormalities. And so that's a large amount of patients. I mean, 4 out of every 5 or 9, sorry, that's a lie, sorry. 8 out of every 10 females experiencing that. And this can obviously be multifactorial, but the emotional component contributes to that with decreased self-confidence, stress, anxiety, a fear of recurrence, all of those things contributing. And even the partners experiencing anxieties about initiating sexual activity with survivors. So that plays a big role, and it's just something to put in the back of your mind with regards to, it's not something that you will speak to your patients often about, but it might be something that is worth having a discussion with and referring them on to the appropriate people to support them. So for today, we'll be talking about fertility preservation, more than the sexual dysfunction. And in this topic, there are so many potential barriers. So I think the most important thing is to be realistic and to note that the most obvious barrier is the urgency to initiate treatment, whether it be a patient with acute leukemia or significant, or for lymphoma with significant disease. We have to always, in any patient, do a risk-benefit assessment, and any decision that you make should not have a detrimental effect to the outcome of the patient with regards to the underlying malignancy. And we have to start there, because I mean, that is what we often see. We've had so many conversations that since we started thinking about this topic, every patient that now comes through our doors, we really have we grapple with this and take it case by case and see whether this patient is a candidate or not. And more often than not, specifically the acute leukemic patient, they just, I mean, they are just so unwell, and the urgency to treat is there. So so obviously it's oftentimes just not a possibility. The second barrier are younger patients, which we often encounter, specifically in the lukes. And prior to their diagnosis, they might not have had these thoughts about their future families. So you've got this young patient without future dreams. They've not yet thought about it. They're too young. And then you have their parents. So the over-involved parent, the fear of losing their own child, and then that combination. Sorry guys, can I move? Thank you. The third thing is obviously a lack of training and knowledge. And there I must say, I mean, I've felt upskilled in the last couple of weeks with regards to listening to this, but it's you'll soon see as we go through the data that there's a lot of gray areas, and there's a lot of non-committal type of maybe referencing things in some of the studies because it's so gray. So it's difficult to have a assured way of treating this. And then the fourth thing is, very importantly, if there's no referral pathway in your hospital or in your system, then you will have difficulty with it. So if there's no clear person to send of where to send, if you're not clear about where to send this patient, then likely the patient won't be sent. It's as easy as that. And then obviously the cost of procedures, which will differ between the private and the state sector. So in theory and in an ideal world, this should be standard practice, both from the physician and the patient perspective. Every patient that undergoes chemo or radiotherapy or is for transplantation should have at some point a discussion about future fertility issues. So that should be the standard of practice. But is it the standard of practice? So if you look at on the left side of the slide, from a physician perspective, there was a survey done on a cohort of transplant specialists in Europe, and they found that 87% of these specialists were aware of and they informed their patients, but they only referred 56% of males and 36% of females. So obviously this will be multifactorial. Some patients might not be candidates for referral, but there's still a discrepancy in the numbers. And if you compare that to your patient perspectives, as we see on the right, in this young male cancer survivor study in 2002, it's quite long ago, and it doesn't just relate to hematological malignancies, but it's still in the cohort of young people that have received chemoradiotherapy with, so I think we can take that data and use it. 51 to 70% of these males noted a desire for future children, but only 24% of them actually banked sperm. And when they investigated this, the main reason was a lack of information given by the attending physician. So what is our role? Our role is to make this a part of our standard care of practice. Even if we can't offer it, we must at least have a discussion about it. And I think we can all agree on that. And as you see here on the left side, so that same, in 2002, in the same year, there was another study done specifically looking at oncologists' attitude towards fertility preservation. And 91% of these oncologists agreed that fertility preservation should, for all males, it was a male-specific study, pre-treatment should be done. But 48% never discussed with their patients. And that's a large amount of physicians never discussing it, even being honest enough to say that they agree it should be done, but not discussing it. And they cited having no time for the discussions, the high costs involved, no convenient facilities to do it in as the main reason. I would conjecture that there would be a couple of other reasons, but those were the ones of the noted in the study. And then if you look at the patient concerns on the right side of the screen, in these studies, multitude of studies all show the same thing with regards to the patient's concerns. With regards to their distress about their future fertility, a lot of them feel that there's a lack of information. This leads to depression and a decreased quality of life. And all of this at the same time, while having to deal with their diagnosis and going through their whole grieving process with what's happening to them. This was very interesting to me, that we might not be able to provide all patients with all of the support and the fertility preservation options that they actually require. Sometimes the way in which they present, or there can be various factors as to why we can't preserve something prior to extensive therapy. But this was interesting to me. This is a study that showed that just having a discussion about infertility and the risks thereof can actually lower their distress and improve their quality of life after treatment. I find this very interesting, and I think something to hold on to, that even if we have to give someone the bad news that likely there's a high risk that they will be, that they could have significant struggles with infertility post-therapy or post-transplant, that even just my conversation with that patient can potentially improve that patient's quality of life after it. So I think you can hold on to this specific quote. So before we go on to the male perspective, I asked Gerdien, and it was lovely to do this for us. We just have a small, like a short poll. It's 5 questions, because we are just curious to know whether or not it's truly just us asking these questions, or whether it's perhaps a more national thing where people are wondering how to best approach the subject. So if I can ask you maybe just to quickly fill in the 5 questions, and you'll see it there, just submit it, and then we'll just have a look and see where are we at with regards to whether we are referring or not. I'm going to give you 5 minutes just to do that. Well, 1 minute. Lovely. So I hope that everyone completed the quiz. I'm sorry if I didn't give enough time, but I think it should have been quick.
There's still answers coming through. Shall we just
Oh,
give
oh,
10
lovely.
seconds more, then I'll share the results.
Oh, thank you.
Sorry, Gerdien, I think I stopped the poll, so I'm going
Okay.
to relaunch it. I'm just relaunching it.
I think
Anybody who still want to answer?
it cancelled everything now, so please go again.
Apologies. Apologies. If everybody can just quickly answer again. My apologies. I made a mistake. Looks like we're reaching a slowdown, so maybe we can go to the results.
You can go ahead, Prof.
Elizabeth, can you
Yes.
see it? And I will move, I'll scroll up if you can't do it from your side.
No, I can. Thank you so much. Thanks, Gerdien. Thank you, Prof. So yeah, so I'm just going to quickly run through it and see what the results are. So firstly, do you think you have sufficient knowledge regarding your agents used and their fertility implications? So 69% said no, which then I'm very glad that we're doing this talk, and I almost want to thank you, because I felt as if I was the only person who had to go read up about this. And then the second one, are you comfortable having a discussion with your patients about future fertility implications? 72% said yes, which I'm thankful to hear. It's good for our patients. And then thirdly, do you discuss future fertility complications with your patients before initiating? And 61% said more than half the time, which is excellent. So do you refer patients at risk for long-term fertility complications for fertility preservation? 58% said sometimes, which is good. And 3% said always, which probably makes sense because we won't necessarily always refer patients. And then are there optimal referral pathways at your institutions to refer patients for these preservation? And 67% said no, which is also almost want to say an excellent answer, because that means that after this we can all go to our institutions and try to optimize these referral pathways. Thank you so much for answering. Perfect. So just want to go back. All right. So now we're going to go a little bit faster and look at the male perspective. And what I thought of doing was just noting some cases we have at the moment, noting the different challenges that we face, specifically towards the male. And we have to start with the ideal. So this gentleman, it's a 27-year-old male. He was previously well. He's a smoker. He's diagnosed with Hodgkin's lymphoma on a right axillary lymph node in June last year. Had quite significant involve of disease. And prior to being referred to us, he was referred from private. He had fertility preservation done in the form of sperm cryopreservation, and then was treated with ABVD until end of last year. He had a good partial metabolic response, but in Jan of this year, his most recent PET showed disease progression and is now undergoing salvage chemo with a planned future transplant. So this would be the ideal patient where prior to, specifically in the male, prior to actually starting chemo or radiotherapy, having done fertility preservation. So the less ideal ones, so this is a patient that we have that's admitted in our ward at the moment, a 16-year-old male. He was previously well and he was admitted with newly diagnosed TALL. And the challenge here was the severe disease on presentation. So he presented with a severe hyperleukocytosis, complicated with epistaxis, a retinal bleed with decreased visual acuity, significant lymphadenopathy with dysphagia, and he was treated urgently post-marrow with cyclophosphamide and intravenous dexamethasone, and he's improved a lot, and he's now receiving induction Grail protocol. He had some other challenges as well, in the fact that he was an adolescent patient presenting with severe disease. So soon after being admitted, the parents and the patient were consulted regarding their wishes for sperm retrieval, more so because the patient is an only child of his family. And here we had a couple of hurdles. Firstly, being the fact that he was acutely unwell. The second thing being that both the patient and the family were just totally overwhelmed by the acute disease, and they really struggled to process all of the information. So whichever decision we needed to make, the parents were continually asking for more time and more time to make decisions, not just talking about fertility, about everything. So an adolescent young patient is just difficult for those reasons. And then adding on to the potential wish to do sperm retrieval, it made for interesting discussions amongst us with regards to how we approach this with a young male. Eventually, he was referred to the andrology lab, and he also had significant difficulty with depositing a specimen, which had to be repeated. And when I followed up on the outcome, unfortunately, no viable sperm was banked. This can obviously be attributable to several things we will talk about soon. So a fourth challenge, we have a patient that 31-year-old male, is known with multiple myeloma. He was diagnosed in 2021. He had significant disease with regards to pelvic plasmacytoma, was treated with radiotherapy at quite a high dose to the right hemipelvis, was started on cyclophosphamide, thalidomide, and dexa. And he was counseled regarding sperm preservation, but at that point they declined. And he received the autotransplant in February of 2022, presently on maintenance thalidomide, and he now wants to start a family. And he requested referral to the andrology lab, which we did, and presently he is still azoospermic. So we will go into a little bit of like some of those situations again in our discussion, but this does leave us with a couple of questions. Firstly, the biology of sperm. Secondly, the effects of chemoradiotherapy on sperm, the different treatment regimes, the effect that the different treatment regimes will have, and then what are our options. Obviously, for the options part, we're specifically more leaning towards the state sector. It would be interesting to know what is being done in private. So if we just talk quickly about the biology of sperm, because it's important to understand the difference in female and male biology to be able to explain to your patient what the implications are. So sperms, we can look at the drawing, but sperms forms continually from this spermatogonial stem cell pool in the seminiferous tubules that you will see there. And it develops into a mature spermatozoa in 74 days. So it takes quite a bit of time to develop a mature spermatozoa. And then once it's mature, it's stored in the epididymis until it's released. So this is now just showing where your Leydig cells and your Sertoli cells are. So in a developing male, you've got this constant interplay between the different cells. Your Leydig cells produces your testosterone, and they're important for your secondary sexual characteristics. Your Sertoli cells, as you can see there, they're kind of interspersed between your developing spermatids and spermatogoniums. And they are the ones that initiate and maintains the spermatogenesis. So it's firstly important to note that even pre-chemotherapy, it's common to have low sperm counts, especially in patients who are significantly unwell, if they are constitutionally very unwell, patients with leukemia, patients with Hodgkin's. So even pre-giving anything, they could have poor or low sperm counts. But chemotherapy specifically damages your spermatogonial stem cell population, leading then to azoospermia or oligospermia, so either nothing or very low counts. Your Leydig cells, again, just noting them where they sit, remember they are the ones producing testosterone, so they are less affected by chemo. And so in your adolescent patient, you should still see your secondary sexual characteristics. But that just means that if you have a adolescent patient who's being treated by some other chemotherapeutic agent that's that has a high gonadic toxicity, then just know that they can still have secondary sexual characteristics, but actually have an associated azoospermia. So the two don't go together. You can still have a normal testosterone level, but be azoospermic. So your most toxic agents are your alkylating agents. So if you think about cyclophosphamide being an alkylating agent, how often we use it, and your platinum chemos. And once your patient is exposed, there is this delayed decline in your sperm counts. Because as you can see at the top there, the key concept here is that your sperms are preformed. So your sperm is preformed, you get exposed to this this chemotherapy agent that's perhaps an alkylating agent, and you won't see a sperm count decline, but you have to know that there's immediate DNA damage, and therefore you cannot bank it. So once you have started with chemotherapy, you cannot bank that sperm. So it's just important here to remember that your sperms are preformed. Radiation, we think about the effect on your of the gonadotoxic effect. Your testes is exquisitely sensitive for radiation. So if you look at the amount of grays there, less than 0.1 will already impair your sperm production, and more than 6, you can potentially be permanently azoospermic. So if you think about our gentleman, the 31-year-old male who had extensive radiotherapy because of these large pelvic plasmacytomas, and now being azoospermic, we don't know yet, it's too soon to tell. We don't know yet if he is a permanent azoospermia, but the amount of radiation that he has received, it could potentially be that he has a permanent azoospermia. So just to know that radiation the testis is exquisitely sensitive to radiation. So the next question is our different regimes and the effects on sperm. So that your different protocols will definitely influence your risk. So your alkylator-rich regimes, as we've just said, can also have a risk of azoospermia of more than 90%. It might not be a permanent thing, but your risk is there. So you could potentially have a transient oligozoospermia, and that would be with a treatment protocol like ABVD in a Hodgkin's patient, where they would have recovering counts after 18 months. And then just to note that your conditioning treatments for transplant that include chemo plus minus radiotherapy are the major threats to fertility. And that's why I know that I asked Jonathan about the GSA's protocol, and it's one of the things on the tick sheet is to, prior to transplantation, refer them, and that is absolutely right, as seeing as that is the biggest threat to their fertility. And I found this a very useful table, and that's in the Lancet article I was referring to, where it just has, it's quite simple to read, and you can just try and find your leukemia or your lymphoma there and what you're treating them with to see what the estimated gonadotoxicity is. And there where I've indicated, if it was very random, but I just decided to just take some random ones and just show you how easily it works. You can look at your AMLs, relapsed AMLs, the conditioning for transplant would potentially have a high estimated gonadotoxicity, and you kind of know what you have to do. If you look at your non-Hodgkin lymphomas, standardly we use R-CHOP, so you'll have large amount of cyclophosphamide, potentially medium to high estimated gonadotoxicity. And then if you go to your Hodgkin lymphomas, in the adult, like usually we use ABVD as kind of first line therapy. So your dacarbazine has some gonadotoxicity associated with it, but it's lower. But should there be pelvic irradiation, obviously then we know it would be very gonadotoxic. So it depends on what you use, what the effect will be. This is probably one of the most useful things that I found when I was reading. So because we use cyclophosphamide so often, and there's a lot of data around cyclophosphamide and not necessarily around the rest of the chemos, they've developed this tool, and you can literally put it into your Google. So it shows you the cyclophosphamide equivalent dose. So equivalent dose of 5 grams per meter square is associated with a substantial lifetime risk of infertility in males and females. So it's very user-friendly. You just put in your dose of whichever agent you used, and it gives you a total CED, which is your total cyclophosphamide equivalent dose. And if that is more than 5 grams per meter squares, then you know that you're in that territory where there's a real substantial lifetime risk of infertility. So the next question are, like, what are the chances of recovery? You've now had your patient, you've given them all of these potentially significant gonadotoxic agents. So if they are now azoospermic post-therapy, what can we expect? How long will it take for them to recover, and will they recover? So the probability is related to the damage of these spermatogonial stem cells. So, and that then implies your dose of your alkylated therapy and whether or not you used any radiotherapy. So the risk is dose dependent. And you'll see there that if the cyclophosphamide equivalent dose is less than 4 grams per meter square, which it says in some studies, or 5, as I've showed you on the tool, you're at a lower risk. But with any alkylated therapy, there is an increase of risk. So for every, so you'll see there, azoospermia will increase with 22% and oligospermia with 14% for every gram per meter square increase in your cyclophosphamide equivalent dose. So everything does come back to your dose, and that will increase your risk. So will there be recovery? So recovery may even occur after intensive therapy in about 25% of patients. In some studies quoted 50%. So we can't always predict who will have recovery. But we know obviously that if you had someone with significant disease, significant dose of alkylators, significant radiation history, then you have to counsel them that they could have potential permanent azoospermia or oligospermia, but we can't predict it. But they do say most patients will recover 12 to 18 months post-treatment. So you can use that as your cutoff to say at 1.5 years, send them to the andrology lab and see where they're at. But for some patients, it might take up to 5 years post-treatment for them to really recover. We know that overall, patients who are significantly treated are less likely to have children. So what are our options? So the golden standard is sperm collection. And I mean, you would have known this before I even started talking, but just some things which I hope will be helpful. So even prior to treatment, as stated before, it's common to have poor sperm quality. So specifically with your lymphoid and your AMLs, your leukemias. So your lymphoid leukemia has the worst pre-freeze total motile count, and your myeloid has your worst post-thaw TMC, which is your total motile count, which just means that your leukemias, if you take a pre-treatment specimen, likely they will have a poor quality specimen. And this, I think, is contributable to many things. But in a study where they looked at adult testicular autopsy samples taken from patients who had died of leukemia, but had no evidence of testicular involvement before death, they still found leukemic infiltrates in 40 to 60% of patients. So what they postulate is that the malignant infiltration into the sperm stem cell niche, it disrupts it, leads then to poor sperm quality and quantity. So we know then that prior to treatment, it's already bad. Post-therapy, we'll have a talk about just now. So your goal is then to obviously send them to the andrology lab, take 3 samples for then either future insemination, IVF, or ICSI, which is intracytoplastic sperm injections. And then if it's a patient with leukemia, then perhaps to take more samples, because of the poor TMC. And then just to reiterate, you have to take the samples pre-treatment and not during treatment, as we've spoken about the DNA damage that occurs with therapy. So sperm retrieval, I'm not going to say too much about, because in the state sector, we, I think, only have the option of sending the patients themselves to the andrology lab. But essentially, we know that ejaculation is how it will happen. So obviously, the challenge is in your peripubertal boy and will depend on his physical and emotional maturity. It's also a challenge in patients that are weak, if they have significant constitutional symptoms, if they have limited movement after biopsies or surgery. So it's not just as easy as that. But at least it's something that can be done for most males, either leukemias or lymphomas prior to treatment. So if you have a peripubertal boy that cannot provide a specimen, then there are some other options which in our setting we can't do, like electroejaculation and TESE, so testicular extraction of sperm, and both of these are done under general anesthesia. And I'll be honest, I don't know of a hospital that does them. Maybe someone else does. So, and then the last one in prepubertal boys, there's this experimental procedure of a testicular tissue cryopreservation. It's the only option that you really have for prepubertal boys. And it's still seen as experimental. And as of now, there's not been a report of a reimplanted testicular tissue leading to a live birth. So post-therapy, now we have a couple of questions. So firstly, how long can sperm be cryopreserved? In the one study I read, there was a 2004, they quoted a 2004 case report of a live birth from a sperm that was cryopreserved for 21 years. So it can be preserved for quite long. And then the second question is, so once the patient has now undergone therapy and they've made they've deposited a specimen prior to receiving it, how do they decide then about what to use, the banked sperm or the post-therapy sperm, and what would actually guide that decision? So firstly, we have to remember that your pre-treatment might have poor quality, and then your post-treatment, it depends on the type of malignancy. The chemo use, the duration, radiotherapy, and whether or not transplant was the patient underwent a transplant. So it will depend. If it will have to be a case-to-case discussion with the patient. So, and then a very important thing is there concern for ongoing damage to the sperm with risk of miscarriage and fetal abnormalities? So, and here it will depend about the extent of the damage and whether the damage was to the stem cells, the spermatogonial stem cells, or were later stages of sperm development affected. So there is this rule of thumb that without good data, they suggest that 18 to 24 months of contraception post chemotherapy is used, but you'll see later on in some of the flow diagrams that we have that they actually note 6 months. So, and that's just, you'll see that no two studies will actually use the same amount of months, just because there's a lack of data on that. But they have detected DNA damage in the sperm up to 2 years after therapy and even longer. So it's something worth noting. And I think if you want to guide your patient, rather use the conservative 18 to 24 months of contraception post finishing chemotherapy. So if you have a patient and you see that only the late stage of spermatogenesis is affected, and that means that the sperm that is not, or the patient is not azoospermic, then potentially you could argue of saying, okay, after a year, you can go off contraception, stop using contraception. But if the patient is azoospermic, that implies that the earlier stages of spermatogenesis is affected, and then we'd rather use the more conservative 18 to 24 months. So in our setting, we actually have a wonderful andrology lab, and it's amazing. It's free of charge for any patient with a malignancy. It's easy access. You phone them, you send them. It's as easy as that every day. And they actually take quite a fair number of specimens. So they call it strokies. They take about like 12 samples of 0.5 ml for every patient and for every time they go. And but there are a couple of things that I think are nuanced and needs to be discussed, and obviously they will as well, because the patient will have to consent when they go to the lab. But I think the important thing to note is adolescent patient, where you need the parents' involvement, and I think also as part of the process to explain what's going on, and then as a legal document, it's so important for this to be filled in before saving any or freezing any specimens, just because of the possibility of the patient's demise, and there then being a big legal aspect to what happens to the samples. And as you can see on this form, they have to clearly indicate if it has to, in the event of the patient's death, if the sample has to be thawed and discarded, or whether it has to be assigned to the care of a wife or partner, and they actually have to be present and have their ID there. Should be used for scientific research, or offered for a donation to a couple. And these things are very important. As you can imagine, the fights that can occur. If you're thinking about our young boy of 16 who's the only child, and if he had something at the andrology lab frozen there, what could happen with that? So you need to, from the outset, before the patient deposits anything, this has to be done. So that brings us to our female perspective. And again, we're going to just quickly look at one of our patients. It's a 22-year-old female. She's previously well. She was diagnosed with Hodgkin's lymphoma on a mediastinal mass biopsy in 2021. She had significant disease. She was initially treated with CBVD, and then switched to ABVD, and up until the end of therapy. Unfortunately, end of treatment PET still showed some residual disease, with progression on the restaging PET, and after which salvage chemo was initiated, and she's now for transplant. We had discussed fertility preservation with her, and the patient declined, and the family were also quite involved, and as of now, she's in remission, and we're going forward with the transplant. So the reason why I chose this patient is just that, as we had said at the outset, that initially patients will present in a significantly unwell, like she did with a large mediastinal mass biopsy, was significantly unwell, and then the PET not showing remission but showing residual disease. So having that time frame where we could actually do fertility preservation. But in the end, it is a discussion with the patient. And so even though nothing is preserved, if you will remember that quote, hopefully, should there be any difficulty with her falling pregnant, just the fact that those conversations were had will hopefully contribute to some, to some improved quality of life post-therapy. So the same questions remains for the females versus the males. So the same questions of biology, effects of chemo and radiotherapy, different regimes, is there chance for recovery, and then the options. And before I start, I mean, anyone that's now tried to manage this in a female will know how infinitely more complex and difficult it is with females compared to males. So the differences are very important, and that's why I've tried to focus on the male biology to show you how easy it is. There's unlimited number of sperm produced. You've got, millions per day. In the females, they are born with their lifetime stockpile, so which then just gradually declines until you have menopause. And menopause usually will be about at the age of 50. So in essence, with the female, it's all about the egg. So when you in utero at about 6 months gestation, you will have about 3 to 7 million primordial follicles, as you can see on the screen there at the left side. Those are the primordial follicles, and then they mature and grow. At birth, you'll have between 1 to 3 million, which declines with another 50% at puberty. So then you're sitting at between maybe at 2 million. And it's when at the time of menopause, you have less than 1,000 primordial follicles left. So at puberty, under the influence of the pituitary hormones, some follicles start maturing, and then you obviously then gradually get to a place where 1 to 2 mature eggs are released every month. And the important things to note here is that these developing follicles produce a hormone that we can measure, and that's your anti-Müllerian hormone, so your AMH. So with regards to chemo, radiotherapy, and the effects of the female reproductive damage can be divided into that, your chemo, radiation-induced, and then bone marrow transplant-induced. So with regards to, with regards to chemotherapy, it has the same type of effect that you will have on your spermatogonial stem cells. Here you will have it on your primordial follicles, but also on the rest of your follicles. So we know that chemotherapy obviously attacks rapidly dividing cells, but via a multitude of different reasons, of different mechanisms, chemotherapy can actually attack your rapidly dividing, more mature follicles, but also your primordial follicles. So it activates apoptotic pathways of your mature and your primordial follicles. It causes fibrosis of the ovarian cortex and the stromal blood vessels. Then you've got diminished blood flow to your primordial follicles. And this is important ones. They actually activate your resting follicles, which then leads to this kind of hyperactivation, which leads to a burnout effect. So obviously the effect of that will be that you at a faster pace go through your follicles than what would a normal female. And one of the most under-recognized consequences of such toxic chemotherapy is premature ovarian failure for this reason. So as we've said, menopause is if you have your menopause, or if you have less than 1,000 primordial follicles, and that usually is around the time of 50. So now you can bring that a decade close of, you can bring that down with a decade. So you have menopause below the age of 40. And as I said, it's such an under-recognized thing. And again, it's your alkylating agents that have the highest risk of premature ovarian failure. So it induces this recruitment of your follicles with burnout of your ovarian reserve. So this leads me to just note some certain misperceptions that I had, and maybe some of you have, is that amenorrhea does not equal infertility. So post-therapy, females can have amenorrhea, which will then recover. But if they then have a normal menstrual cycle, it doesn't imply that they have adequate ovarian reserve. If you use your normal, if it's age, LH, or cyclical menses to determine whether someone has ovarian reserve, you can definitely overestimate their ovarian reserve, because you don't know when they're going to run out. When are they going to be at that point when there are less than 1,000 remaining follicles? So what you can use, you can use your anti-Müllerian hormone, as we've just, as I've noted to. So it just gives you a better idea of your ovarian reserve. Radiation has a intense effect on your ovaries, just as it has on the testes. Your ovarians are also very, very sensitive. So it depends on your age, on your radiation field, and your treatment dose, but it is directly toxic to your oocytes. And at about 2 grades, 50% of your oocytes will die. At larger doses of 16, you'll have immediate sterility. And if you look at the right, I'm not sure that you will see it if you are looking on a smaller device, but dependent on the age of treatment and the amount of and the intensity of radiotherapy, if you look at the top line, it brings down the age at which you will have ovarian failure. So so obviously the earlier and the larger the dose, the bigger of the earlier the ovarian failure. So the radiation doesn't only have effects on your your ovarian damage. It also has uterine damage. So it's dependent on the age and the dose again. But as your uterus develops at puberty, it increases in size, it increases in vascularity, and specifically if you have radiation in those times, in that specific time of your life, it can have a lot of long-term consequences. So it causes fibrosis, reduced vascularity, hormone-dependent endometrial insufficiency, and then obviously longer term, if you're looking at when the patient then wants to start a family, you will struggle with increased infertility, miscarriages, preterm labor, growth retardation, low birth weight, newborns. So it does have a significant effect both on the ovaries and on the uterus. If you look at your different chemo regimes, I think it can feel overwhelming if you think about all the chemotherapies that there are. And I will make it more clear at the end with some nice protocols that we will share later. But essentially, with your acute leukemias, your risk of premature ovarian failure is very low. It's less than 20% with the standard induction and consolidation treatment chemotherapies that we give. So usually in the acute leukemic patient, they won't go into premature ovarian failure post therapy. With your Hodgkin's, if you use ABVD, it's, as you can see, it's there's a comparable birth rate to the general population. So it's only with the escalated regimes and the addition of significant doses of alkylating agents where your risk obviously increases. With your non-Hodgkin's lymphoma, so obviously we know the ages of the patient might preclude them from fertility future wishes, but we know that a population of non-Hodgkin's patients will still be in that age group. And even though we use a lot of alkylators, if you think about just standard CHOP or R-CHOP, there's still a less than 20% risk for permanent amenorrhea, but obviously with escalated therapy, as they often need, there can be more insufficiency. So you can use the same table that we used for the males for your females, because it just shows you whether or not there's gonadotoxicity. And should you want to refer to something, I really want to just remind you of this. So in terms of bone marrow transplant, I think the take-home message is just to know that, and what we have said before, is that obviously it depends on your conditioning protocol, whether or not it's chemotherapy alone or is it with associated radiotherapy. But either or, it has an extensive reproductive potential to preclude your patient from ever realizing their fertility dreams. So prior to bone marrow transplant, you have to be sure that you have that discussion with the patient. But just to remind you of the fact that there's a lot of vaginal damage associated with GVHD, and so there's a lot of post bone marrow transplant effects that come into play, more than just the pre-transplant chemo and radiotherapy. So the options that we have available to us are just obviously it's the one that you know about, your controlled ovarian hyperstimulation. And what's nice is that they can do it independent of a menstrual cycle. So they can just start on day one, whenever day one of referral is. It's 10 to 12 days, after which they can harvest. But it's important to note that obviously you're delaying definitive treatment by 1 to 2, maybe even 3 weeks. And that just makes it often something that we obviously cannot afford to do if it puts the patient at risk for their underlying disease. So there's a couple of other things to consider. You're adding on all these kind of hormonal stimuli, and that can lead to a lot of high estrogen levels. There's a risk for thrombosis. You'll have to just assess your patient well. And often it's because of the invasiveness of the procedure to go harvest the oocytes that make it unfeasible. So if the patient has a cytopenia or there's an infection or you're at risk for infections, then it's not a feasible thing in the acute leukemia patient, for instance. Second is ovarian tissue cryopreservation. This is something that I'm not aware of any African patient who has actually delivered a baby after having ovarian tissue cryopreserved. So it's still in the kind of developing phase, but they are starting to do it more. This is an option for girls who are not yet mature enough for your controlled ovarian hyperstimulation, or when there isn't sufficient time. So what they do is they take out the entire ovary or sections containing primordial follicles. They take it out via laparoscopy, then freeze those entire sections. So then post-chemotherapy, they reimplant the tissue into the ovary, the fallopian tube, or the peritoneum, and then most of the time would then have another stimulus, extract some of those oocytes, and then have a cycle of IVF or ICSI. So worldwide, there's been about 360 transplantations that have taken place, with about 130 live births having occurred. So you can think it's quite a nice viable option for some of our patients if it has to be done rapidly, and then you can go on with your therapy. But there are some advantages and disadvantages to think about. So firstly, advantages: your harvesting can occur immediately, as we've said, and a male partner is not required. You can restore someone's full endocrinological function post-therapy, and it's the only option actually for prepubertal females. The biggest disadvantage is the fact that you have a concern of a malignant contamination of the ovarian tissue, and this has been shown in patients with CML, ALL, and AML, where the tissue tested positive for this disease in a number of cases. So they don't recommend it for leukemia, but there have been patients who have had lymphomas where they were histologically negative for the disease, and they've been transplanted without initiating a relapse. So potentially in our lymphoma patients, something for the future. So this is something that's very controversial. I don't want to say too much about it, but there is this entity that they refer to as GnRHA, so gonadotropin releasing hormone agonists. So it has an unclear mechanism of action with regards to exactly how it would be of benefit. There's some evidence in patients with breast cancer where they've started using it, but as of the haematological malignancies, there's no clear data, and we don't suggest it at present. Obviously, if you think about the fact that that your primordial follicles become recruited, I mean, that would be the postulation of how it works by suppressing that and suppressing menstruation. It has a possibility of being a future adjuvant to our therapies. So as a bit of a tiger book perspective, for the female patient, in our setting, we usually find that specifically in our leukemic patients, they are usually acutely too unwell. Even in our male patients that are acutely unwell, we can quickly send them to the andrology lab. We sort them out, they get back, we can do what we need to do. But often, whether or not it's a leukemia or lymphoma, they're very unwell, and you have to really think whether or not you can wait those up to 3 weeks to do this prior to therapy. Whereas the males are free of charge, the females, there's no cost to the patient with regards to the procedure and the storage, but it costs the females about 9,000 Rand to go buy the medication that they need to induce a cycle privately. So it does have a significant cost to the patient themselves, even though it's much less than it would be for everything else in private. The cost of the medication is still prohibitive to a lot of our patients. And then the reason why I wrote they're less experienced is just that I think it's one of those things that because we don't do it often, we are not always sure exactly where to start with regards to the referral, even though we do have a very helpful service at our disposal. So it's a muscle we need to start flexing more. So I think the take-home message for us with our females is where the males are quite clear-cut, the females always needs to be planned on a case-by-case decision, and you really have to look at your algorithm for when you need to preserve, and not just preserve prior to transplant, but also think about the underlying hematological malignancy and see whether this patient is whether we should preserve sooner rather than later. So for anyone that wants to read a bit more, and I'm going to just say a couple of things in the next 3 slides, and then I'll probably be done. But this I found very helpful after reading a multitude of of different studies who all said the same thing, that alkylators are bad, transplant is bad for fertility. No one really had a clear algorithm with regards to how long to wait post chemotherapy, when to exactly do it, what they would suggest. And it's because of this big gray area. And I don't agree with everything on these slides, because it doesn't, some of the time frames are a bit different from the literature that I read, but I found this the most helpful. So yeah, if you want the study, then I can share it with you. And what you will see is it's a lot of small writing. I apologize, but essentially it gives you an idea of the different approaches to either a patient with leukemia, patient with Hodgkin's lymphoma, or patient with non-Hodgkin's, as easy as that. And essentially what they say is, for your leukemic patients, because hopefully we will have them in remission and treated with the first-line therapy, which doesn't have a significant gonadotoxicity to it. So they don't suggest that we do pre-therapy fertility preservation in the females. Males, you can just always send them. Like, it's always better to send them and get the pre-therapy semen sample, but the females, you can actually rather wait. And here it becomes tricky, because then they say if there's second line treatment, it makes them more high risk, and then kind of at least 6 months after the last dose of chemotherapy, then to try and do fertility preservation, because at that stage, obviously, you'll send them for a transplant, and then they might not have another chance. But that is a bit impractical. So it practically speaking, you'll need to see how it works out, but they don't, in the acute leukemic index presentation, actually suggest that you send a patient for fertility preservation. In patients with Hodgkin's lymphoma, it's almost the same, because we have such a high chance of cure with the first-line treatment. You can offer preservation advice, which is important, but you don't necessarily need to send them for preservation. So if you use ABVD, hopefully you can, and you don't need to use CBVD, which can add the risk, obviously. But if you can do ABVD, then you don't need to send them for preservation. You offer them advice, but should you need to use a higher risk protocol with a higher alkylating agent amount, then, or if you need to send the patient for pelvic radiotherapy, then it would be a very good idea to do pre-therapy or pre-radiotherapy fertility preservation. Again, in the males, just send them. Non-Hodgkin's lymphoma, because our first-line therapy is already an alkylator based regime, it would be of value for you to send them, because they have a high risk of a high chance of needing escalated therapy, which would then include more alkylator therapy. So both in your females and males, they would consider sending the patient. So this just makes it a lot easier. And I think the only thing would be to familiarize yourself with the different agents and which of them have alkylators or platinum in them, and to know that radiotherapy has a significant consequence for both males and females. Yeah, I don't want to say too much on CML, because I feel I've now said enough, but I'll just note that there's scanty data for males with regards to anything more than imatinib. There's been some data that suggests a man can, even while on imatinib, safely father a child, but the data isn't great, and even less so for the next generation TKIs. So they encourage you to still rather cryopreserve sperm prior to initiating imatinib. And then with women, obviously, we would never want to really stop therapy just for the sake of a pregnancy. But should you have a patient that is consistent with her wishes, the ideal would be for her to achieve MR and have it be so for more than 2 years, and then to discontinue, attempt pregnancy, and then reinitiate, while also obviously then just making sure that she understands the risk of not responding again on reinitiation of therapy. The best would probably be to take her off the imatinib, send her to get controlled ovarian hyperstimulation, rather freeze some oocytes or embryos depending on a relationship profile, continue then again with imatinib and rather use a surrogate. So I know that was quite a mouthful for me as well. And I hope that I've left you with less questions and not more. But yeah, I just want to first just ask, are there any questions that someone would want to ask us?
Thanks, Lizette, for a lovely presentation. I think it was quite comprehensive. May I suggest you go to the chat box first?
I don't know.
Yeah, from
Yes.
my side as well, Lizette, very practical. Thank you for that. A very lively chat followed alongside your presentation. So there's some interesting questions there. Maybe, yeah, I agree. Let's start there and then take some others.
Yeah, so I think the first question was from Jacques, an interesting scenario, a patient who multiple myeloma, who was post-transplant and now wants a child. Jacques, I just wanted to ask, did he have advice for fertility before he had his transplant? Was he offered fertility preservation?
Fatima, I am not sure. He was not treated by our center.
Okay.
He was obviously aware of the issues surrounding obviously the use of the IMIDs and needing to. So his wife was actually on contraception, but I'm not sure if he had any discussion prior to auto transplant.
Okay.
I will actually find out when I see him again. When I
Yep.
saw him last week, the focus was around what we're going to do now, because they sort of voiced this wish to have children, and he's not been on treatment now for about 6 months due to various reasons. He got lost to follow up, and so yeah, the issue is we've got a young man with myeloma who we preferably would like to have on the optimal therapy for myeloma, but then also, yeah, it's a year post-transplant, and it would be good to give them a chance to have children. So yeah, I think it's actually
So
quite a
his
tricky
myeloma
scenario.
has he had a stringent CR? He's fine, is it?
He's I don't have his, I mean, I only saw him last week, so I don't have his recent results, but he's clinically quite well, but I don't know if he's in a stringent CR right now. I'll have to see what he's, we did his markers and we'll see what he's, where he is now. Yeah.
Because, so again, with the newer agents, the data is limited, but, just in terms of he's had a break for 6 months, perhaps you can send him to the fertility clinic for preservation and then possibly recommence. Because, with the lenalidomide, if you have had a 4-week break from lenalidomide, it should be fine in terms of sperm retrieval.
Yeah,
I think do you want to comment?
agree.
Yeah, I think my first question would be, and it's just with regards to, I mean, he's now been through transplant, it's just with regards to a semen analysis. I think that's probably the best place to start, because it might be that he's azoospermic, and then this whole conversation is a bit different. So that would probably be the first step. Second step is that while on lenalidomide or thalidomide, definitely not. I mean, it's present in the semen of males, so you'd rather not want to use that. But I would also think the best would be to actually use this opportunity for him to bank sperm, put him back on his treatment, and they can rather go IVF route rather than going the risk of disease recurrence. Yeah, that would probably be the best. Yeah. Does that help? I'm not sure.
Good. Yeah, no, absolutely. Thanks for all the comments.
Doc, I've thrown in a link for you. This particular article has 2 different cases, and one of them is a male who's actually had 2 transplants with high-dose melphalan conditioning in both, who recovered fertility, and the other one is a female who had fludarabine melphalan. So maybe worth having a look at those articles or that article.
I'm just trying, I see there was a nice conversation. I'm just reading through everything in the chat box. Thank you, Prof, for that as well. All right.
So I noted the results of the poll. They were very interesting, I must say. There's quite a mix of experience across the country. I was hoping there's somebody in the audience from the private sector. I suppose most of the challenges will be in the state sector in terms of access to fertility preservation. I noted that Dave Britton was on earlier. I'm not sure if he's still on.
Yeah, I'm here. No, thank you. Thank you very much for a very good talk.
Yes.
I think, you know, it remains a very relevant topic, especially for younger patients. And that balance between the urgency of therapy versus getting things done is a huge thing. And since it's not funded by insurance companies, fertility preservation remains a problem in private sector as well. As was pointed out, especially for women. I mean, storing semen is quick and easy and relatively cheap. And it's a couple of grand and then about 1,000 Rand a year after that. So it's not out of reach, but for preserving especially, in patients like leukemic patients where you might harvest, treat leukemic cells, and the whole issue of like delaying treatment and balancing that, especially for aggressive diseases, is massive. And as you often point out you point out often they have a very high cure rate. And so is it appropriate? But if they don't get cured, they often go straight into salvage and then into transplant, in which case the opportunity is lost. But I mean, Jacques' case highlights the importance of counseling, really, and let the patient make the choice and the decision, and let them at least understand that there's a problem.
Yeah, I think sometimes we focus so much on curing the patient that gets left behind. And we are proposing, in our unit to actually have an informed consent sheet. We focus on contraception and consent for the chemo. And we're going to try and make it standard to include a discussion on the fertility preservation as well at the outset, so that patients are aware of it. I think, as you say, it'll be easier for males and females, but there are some patients who can afford the hour setting. The gynae department has the skills and they're prepared to do it. So I don't know about the other state hematology units. What is their experience like as well? Thanks. That was very useful for us, because we always assume that the private sector has everything available.
The other thing is that it's absolutely devastating for a young woman to be faced. First, they're trying to deal with the diagnosis of their malignancy, and then you immediately throw in this thing that they're likely to be infertile, or they're possibly infertile and menopausal after your therapy. And so I think further counseling is needed. But it's a good idea to put it in the consent form, because then you filter it. People, some people say, oh, well, I've got 5 kids and I'm sterilized, or I've had a hysterectomy. It doesn't matter to me. But at least you don't miss people, which is what you're trying to prevent.
Although we've had the experience where sometimes patients are so overwhelmed with their initial diagnosis that they don't even want to think about, the long-term implications of therapy. Other comments? Anybody want to ask a question?
I'll just make a quick comment. I think this is a very important topic for us at the deep dive to do maybe every 2 years or so, because there are some very interesting new developments on, sperm stem cell regeneration. I also just commented on oophoropexy, where they move the ovaries out of the way. The surgeon can do that, stick it to the abdominal wall or wherever else, or somewhere out of the way, if pelvic radiation is required for whatever reason, especially in our population where we often see these younger myelomas and so on. But there are all sorts of new things coming up and being done. So I think this was very useful. We found it practically useful to invite our local team doing the sperm cell collections to come and give a talk at our journal club. So everybody got to meet them, understand the process, just make things so much easier for communication if you put a face to the practice and to the people who are doing the job. So yeah, that's that from me.
So what has been your experience with females? Do you have access to the stimulating hormones, or is there uptake from the patients to purchase it themselves?
I must say I haven't actually had personal experience of that with any of our patients. I don't know if Cecile or Estelle wants to respond on that from their side.
I can just say that we have not offered any fertility preservation to females in my time. Many of our males have gone, not many that I know have gone back actually for the sperm. And we've also had quite a few patients surprising recover fertility, even patients, a woman who had cyclophosphamide and total body irradiation, who ultimately recovered the fertility and had 2 children.
Wow, that's amazing.
That's lovely to hear. Yeah.
So I think we'll close at that point. Thanks to Lizette for a wonderful presentation, and thanks to all of you for attending. Appreciate that.
Thank you.
Thank you from my
Thanks,
side as
Virgin.
well. And thank you, Fatima. Much appreciated. Have a lovely evening, everybody.
Thank you. You too. Bye-bye.